My goal today is to give you kind of an overview of identifying a patient comes into your clinic maybe with non-odontogenic pain and some actionable strategies that you can give to them right away to initiate some treatment, know how to refer, and some things to look at while you are right in the office with the patient. So, okay, because my presentation's being goofy, I'm going to skip that one. Okay. So, temporomandibular disorders. So it's a whole category, also called oral facial pain, is the 12th recognized dental specialty in 2020. And so, thank you for the laughs, yes. And so, it's a big cluster of disorders, and I'm going to break it down into kind of 3 today that I want you guys to be able to identify. So joint dysfunctions, disc dysfunctions, and muscle dysfunctions. Because I'm sure, if you don't mind raising your hand, how many in the room have some sort of a jaw issue, clicking problem? It's been stuck. There's a couple people at most tables. Yeah, so there's actually about 35% of the population can have temporomandibular disorders at some point in their life. Doesn't always have to limit their function, but it's kind of scary when your joint's making a noise all of a sudden. You don't know what it is, or it hurts after you've been at the dentist or the dental therapy provider. And so having the resources to help these patients right away, I think is really important. So, okay, so what does this look like? What is somebody going to report when you come into the clinic? Sometimes it's tooth pain, right? It's their molar hurts and you're not finding anything wrong with it. Do all of your sensitivity testing, nothing's popping up. Sometimes they're complaining of eye pain, a headache, ear ringing, so tinnitus or tinnitus is a common symptom that can come from temporomandibular disorders. And then sometimes swallowing dysfunctions, pain, of course, in the cheek. This was a study done by a PT and a dentist collaborative group in Texas a few years ago, and they mapped out the major muscles and where they can refer pain for people. So these infographics I use quite a bit to explain to patients why their pain might not be coming from their tooth, right? Again, you folks have kind of already ruled that out, but the patient sometimes is so convinced that like, oh, the pain is in that tooth, it has to be a problem with the tooth, right? And they seek out multiple dental providers who all tell them the same thing. And so this can be a useful tool for education. All right. So, quick review of the anatomy, just to help understand what we're talking about so we can identify those joints, those muscle, and those disc disorders, right? Because that'll help you kind of choose your treatment decisions and or your referral pathways. So, we have, right, the joint. We have a condyle. We have a disc in between, right by the ear. Number 4 is the articular eminence. That's what stops you from opening too far. Some people open too far as part of their problem, get stuck past that, and then they're locked open. That's more rare, but more scary for patients, right? And then the big coronoid process over there, number 6 on the right picture of your page. So, quick review. All right. And then what happens with the joints? So, joint dysfunctions we can break into, again, a few different categories. So arthritis, degenerative changes in the joint. We get it everywhere in our body, unfortunately, as people age naturally. Some have more issues with arthritis earlier in life than others. And then rheumatoid arthritis is one of those that you really want to know about if that's in the patient's history, because that's an inflammatory body-wide condition that can actually cause damage to the joints, including the temporomandibular joint. So, just one of those under the joint dysfunction categories. And then we have inflammatory conditions. So yes, RA is an inflammatory condition, like I said, but you can also have an infection in the joint. You can have capsulitis in the joint, which is where the connective tissue surrounding the bones becomes inflamed and painful. Patients can't open. It really hurts to touch. There might be visible swelling right around their joints. So again, some things maybe that you guys have seen. So something to look for. And then hypermobility disorders, like I talked about, your super flexible people, your dancers, your gymnasts, folks that can do the splits, do these crazy human tricks, dislocate things. A lot of times they can do that with their jaw also. So we treat that differently than somebody who has an inflamed joint. So just, again, to get some categories going in your brain. And then disc dysfunctions, technically it's a part of the joint dysfunction category, but it's got its own special nuances, as you guys are probably familiar with, so I'm going to break that out into a separate section. So, all right, so disc dysfunctions. There's 4 of them that we label with a specific diagnosis. So we have a disc displacement with a reduction, and I'll show you what this looks like in a picture on the next slide. But that's where the disc is clicking on, or the bone is clicking onto the disc, clicking off of the disc. They have a double click when they open and close. Sometimes you can't always hear both of them, but usually they're there if it's repeated every time. Then we have disc displacement with intermittent locking. So that means that the bone is moving onto that disc sometimes, but not always. So then those folks are starting to get stuck, where they say, oh, I can't open, give me a second, let me maneuver my mouth, and then, oh, there I got it, now I can open. Those patients in your guys' chairs are going to have a really hard time holding their mouth open for any prolonged period of time, because they're really kind of fighting to get that bony condyle, kind of like the ball and socket, like the ball of the socket, or the ball of the joint, to stay on that disc. It's kind of teetering and wanting to slip on and off. So they're going to need more breaks. They're going to be afraid to open really far just because they've had experiences where that is painful for them. And then we have disc displacement without reduction. So now these people can't click back onto the disc at all. They're stuck. They're usually limited to about 2 fingers of opening, or around 20, maybe to 25 millimeters of opening if you measure it. Normal is 40 to 45, so they got about half of normal motion. Again, making dental exams and treatments difficult for them. And then the final stage, this is typically progressive. Not always. The time frame for that varies on people. Sometimes they can go through this in a couple years. Sometimes it takes 20 years to get through it. But historically, disc disorders, if you leave them alone and they've followed people in long-term studies, they tend to just naturally kind of work their way through to that last phase eventually. But it's not so fun when you're hanging out in the middle. So we do want to treat those people to get them through it more quickly and with less pain. So that leads us to the last phase of the disc dysfunctions, is that's where they don't reduce, so they don't click back onto the disc, but it doesn't stop them from opening. That means the disc is kind of stretched far enough out of the way that they can open fully and just don't even get on the thing again. And usually they're pretty functional at that point. They've probably gone through a previous painful period, but now it's fairly stable. They can eat, they can chew, they can do most things. And so I know that's all words. Let's look at it in pictures. And then also I've got, if it'll let me do it, a video I can pull up. Right? So again, I know this is anatomy review, but hopefully it'll help tie into when you see those clinical presentations. So we've got, right, normal disc position, the first one. So when you open, the disc just stays in between the bones the whole time, slides along, nothing clicks, everybody's happy. Then we've got one with reduction. So when you're closed, the disc is actually technically out of place, right? The disc kind of sits in front of the joint, and then when we open, we click back onto it. So it's like we relocate or we reduce the displacement. So that's why it's disc displacement with reduction. So they click on, they open, and then at the very end, they'll click back off of it again. You'll usually hear the opening click, not always the closing click, but the patient, they will notice it and tell it to you. They usually want you to feel it and hear it too. Do you hear the click? Is it there? You know, put your hand there, tell them that you feel it, reinforce that, yep, I believe you, I know it's a thing. And then the final stage is where it doesn't reduce. So that's where your disc is sitting out in front. When you open, it just kind of stretches along with the joint and you don't even run into it anymore. So I am going to, let me see if this works for me. And if it doesn't, I won't spend too much time on it. But, okay. Has anybody heard of the Yoint video? We were just talking about YouTube stuff a little bit ago. So, okay. This is a Yoint video. It is fairly old. I'm not going to play the whole thing for you, but it's by 2 Swedish doctors, Westesson and Eriksson, if I'm saying that correctly. But it is kind of interesting because they did, it's a really good one, actually, one, to educate yourself, and then 2, to educate patients. if they're not grossed out by anatomical images. But it goes through a cadaver movements of the joint. So it's kind of like that picture I just showed you where we have the big condyle. The white thing is the disc, and then the articular eminence is the thing in front of it on your right of the screen. So it'd be like a side slice of the patient facing that way if it was me. And so what happens, they do a thing of it moving here. And it's fine that I don't have the sound. Why it's called the joint video is because in their Swedish accents, they say joint is joint. So, and I don't know if I have a good enough Wi-Fi. Oh, there I do. Okay. So, yeah, so sorry, I know it's a little bit icky. You ate lunch a little while ago, so hopefully it's okay. Yeah. I'm going to, yep, so there's where it slides. That disc is going with it there. And then there's an example. So that's a normal one. That's where the disc is staying in place, sliding with the joint, sliding back. It's not clicking. The patient isn't having any problems. And then I'm going to scooch ahead here to look at a displacement. So again, we'll see if it'll work for me here. If not, you certainly can look it up too. But what it's supposed to show, okay. So let me make sure that that's going to demonstrate it. Yep, there it clicks. Okay, so they're off the disc. They kind of slide back onto it, and then they have more of a dramatic clicking back off of it at the close. That's the close, right? So it displaces when you're closed. You get back on it when you open, and then you go back off of it when you close. So, again, kind of interesting. I think it helps to visualize it so you can kind of picture that maybe what's happening with those patients. So when this first starts happening, it's painful because there's a ligament behind that disc. Actually, I'm going to go back to my presentation here. Let's see if I can get back to full screen mode here. Okay, so the little orange or pink thing, sorry, I know this is a little blurry for you guys, that's a ligament that holds the disc in place. So that gets stretched, and when you first start pushing on that instead of the disc, right, because if the disc is in the wrong place, now your bone is pushing on the ligament instead of the disc. The disc doesn't have great innervation in the middle, which is how it's made, so it doesn't hurt us when we put pressure on it, but that ligament does. So that really hurts, and it's inflamed, and people don't like it, and then they're coming into your office and complaining to you guys about it. So what will happen actually is that little ligament will remodel over time. It will form a little bit of scar tissue on it. And so when you're at this end stage of stuff where it's stretched out, you're not running into the disc at all anymore, you got normal opening, that little ligament piece will just function as what we call a pseudodisc. And so you're fine. People can function long-term that way and do just fine. Obviously, there's variations in severity of cases and things like that. But my point of going into a little bit of depth of explaining all of this is I want you guys to also be able to explain that to a patient, or at least at a basic level so they understand what's happening and it's not so scary for them. Because what happens to me a few times being a PT that treats this is I'll get patients that'll come from different providers and they're kind of freaked out, and then that provider wasn't able to calm their fears, so now they think they have some awful thing and they've avoided moving their jaw for a long time, and then we have more problems. So if you can catch these folks early, say, hey, this is what's happening, this is what we can do about it, which I'll give you some tips, it can go a long way to help with the treatment. And then when to recognize when they need more help. So, okay. Questions so far? I know it's like a back to school anatomy discussion, sorry, but it will come into play. So, okay. So we had joint disorders, right? The inflammation, the capsulitis, the hypermobility. We have disc disorders that we just talked about, and then now we have muscle disorders. Oftentimes, a lot of those go together. You tend to have a muscle disorder because you have a disc disorder, or vice versa. So, different things we look at with the muscles. Myalgia is just the term for muscle pain. So it's diagnosis code for myalgia of the jaw, of the masticatory muscles. You can have tendinitis, where the tendon attachment of the muscle is actually inflamed, and that's the problem, versus the muscle themselves. Myositis, there can be an infection in the muscle. You can have spasm or trismus, right? You guys probably know trismus. If it's spasmed enough that it limits their opening, then it's considered trismus. That's an interesting thing I always find. The more of the medical terminology, we don't use trismus usually. It's like spasm or contracture, so it's like specific to like dentistry that trismus is a muscle condition. And then contractures, shortening of the muscle. Hypertrophy, so that's a picture of this guy. When he clenches, right, he's got pretty giant masseters. So folks that have that, you can be pretty confident they're clenching. Clenching is like a workout for your face that you don't want to do, and it builds up stronger muscles. So if you can see their masseters from across the room, you're pretty sure they're overusing something, or play an instrument maybe, but yeah. And then there's, of course, movement disorders, tremors, things like that people can have that affect the face. That would be a muscle disorder too. But mostly we're looking for muscle pain and tightness in the clinic as a complaint. Okay, don't worry, I'm not going to go through all of them, but a lot of muscles in the face and head, right? We have our facial muscles, our expression muscles, our swallowing muscles, our postural, and then we have our 4 muscles of mastication. So those are the 4 we're going to talk through, just again, quick as a review, so you can identify what your patients are complaining about. Okay, temporalis, right? We all know where that is, temporal bone. That's why the coronoid process is so big, because the temporalis attaches to it to give it a point to pull. One of your main, like, clenchers, biting muscles. Masseters, your other one. Again, you guys know this one. Medial pterygoid, so that is on the inside of the mandible. So it's kind of cut away down here and showing it on the inside. Medial pterygoid protrudes your jaw, and then also we'll move it side to side. This one has a connection to the ear tube. So patients who complain of ear ringing, ears clogged, ear pain, sometimes this is a muscle that can cause some of those symptoms. Okay, almost done with the anatomy stuff. Then lateral pterygoid. So that one's way deep in there. You can access it from inside the mouth. And that one tends to be painful if there's a joint dysfunction going on, because it attaches right to the joint. Okay, and then nerves. Sorry, there's one more, I lied. One more anatomy slide. Okay, nerves, right? We also have to pay attention to the patients coming in that have numbness or tingling, right? The trigeminal nerve system causes all sorts of havoc sometimes, and it's still kind of confusing. But you got your 3 branches, and so you got to look for that tingly, shooting pains, those sort of things. Again, something you're probably not going to treat in your office, but recognizing it and knowing how to refer. When you're like, yeah, this really isn't a tooth pain, this sounds like it's something else. Okay, so now what do we do? So we're going to try and identify if it's a joint, if it's a muscle, or if it's a disc problem. So when a patient comes in, you're observing them, right? So you're just looking at them. How are they sitting? Are they anxious? Are they holding their jaw a goofy way? Obviously, you guys are checking the dentition. What's going on there? Do they have, wear patterns, bruxism sign, abfractions, like stuff like that going on that might clue you into that there's a TMD or muscular problem? Breathing pattern, yes, and then anxiety level. Just observation. And then parafunctional signs. So I make parafunctional signs a little bit different in what I look at. I also include like habits and things that are overuse of the jaw. So tori can be a sign of clenching and grinding, right? Because loading the bone more can create more bone growth. That's how we get stronger bones anywhere in our body, right? So same thing can happen in the jaw. People can just genetically have this also, but it's just a sign to look for if they think they're clenching. Because most often patients don't think they're clenching, right? Like if you guys mention it to them, like, I think you clench. No, I don't clench. I don't snore, I don't clench, I don't grind my teeth. I'm not that person. Well, there's some signs that tell us that maybe you do. Right, my crowns keep breaking, my teeth keep breaking. Why do yeah, right? And so then you're trying to convince them, like, instead of continuing to do restorative things, maybe we need to prevent it from continuing to get worse. So, yes, and then scalloping of the tongue is another sign of, posturing, tensing. They're vacuuming their tongue up. They're doing something with pressing it into their teeth. right? The dark triangles. This is just another, she's got big masseters going on. And then I would argue that chewing gum, chewing your nails, chewing on pens, chewing ice cubes in glasses of water that you're drinking all day, those are all also parafunctional things because it's not a normal habit or use of our jaw. So I look for that sort of stuff too. And those are things you can educate the patient on if you're noticing it. Okay. So the other thing I mentioned patients don't always think that they do is snore, or they don't have any sleeping problems or airway problems. So kind of a facial profile to look at. This is called a retrognathic facial profile. My husband won't let me put a picture of him on my presentations, but this is him. He's had his CPAP since he was 29. So, and he's a general dentist. He should know better. But so they kind of have the retruded chin, the narrowed airway. The patient will slouch and have their head forward because they can't breathe if they pull their head back. And so if you're noticing that in the patient in the dental chair, it's a patient that might not want to lay back without a pillow or without being really propped up because it actually does restrict their airway. So I point this out in your observation of the patient because this is something you'd want to, refer for probably to either a sleep dentist or sleep physician or kind of whatever the patient has access to, right, for care. But educating them on this might be a reason why you're grinding at night is there's an airway issue that you're trying to fight for breathing. Okay. Then posture again. So not talking about the airway now, but I'm going to have you guys all try this. So everybody sit up straight, good posture. As soon as I say the word posture, I'm a PT. I had to talk about posture, right? You weren't going to get away without it. So, all right. So you're sitting upright, okay, and then tap your teeth where your, feel where your like occlusal points are and where everything hits, right? Okay. Now slouch, like really make it dramatic, head forward, hunch. Now tap your teeth again. And kind of just check between the two. You should feel like your contacts move posteriorly when you're slouched and in that forward position, right? Most people, that's what happens. That's because when you slouch forward, the muscles in the front of your neck are elongated and they pull the jaw into like downward position and retraction. That'll move, right, the mandible back a little bit, make the contacts more posterior. And then you have to exert more force to keep your mouth closed, so that every time you slouch, your jaw doesn't hang open. So that can also, right, cause problems, issues over time, and it's important to educate people about that for that reason. Okay, so we're still looking at our patient, right? We're observing them, we're looking at their posture, we're looking at how they move. We're just, again, asking them, do you have any numbness? I kind of talked about that a little bit in the other slide. Do they have any shooting pains? And then you're starting to think like, okay, maybe this isn't only like a dental tooth problem. What else might this person have going on? So now let's actually ask them to do some things and watch them move. So you're going to observe opening and closing, right? Observe their talking. If you don't have jaw rulers in your clinic, kind of the 3-finger screen, right, is your average normal. If they can get 3 fingers between their incisors, they have normal opening. If they're less than that, then that may be something to work on. And I use these guys, Therabyte little rulers. I'm not affiliated with them in any way. There's lots of different ways you can measure it, but I like to get a number on it. And then you're also looking at quality and how they move. So if they open, do they go off to the side? Do they have that S-shaped curve, right? So the S-shaped curve usually means they're doing that clicking onto the disc thing. If they have a C-shaped curve where they only go one way with the opening, that's more indicative of a joint problem. So that capsulitis, that tightness in the joint, where the motion in that joint doesn't improve as they open because they're not clicking back onto something. So, and then you'll want to feel it. Like I said, patients will want you to feel it. They'll want you to make sure that you understand, yep, it's there, I can tell, I can hear it, or I can feel it when you're opening. So you actually got to probably put your hands on their joint and just feel them open. And then you can kind of tell too, does the click happen right away? Does it happen later in the motion? If it happens real early and they say, oh, it just started a couple weeks ago, right, they're probably in that stage 1 that I talked about, that clicking with the reduction where they just click on and off, they're not getting stuck yet. If they're telling you they've had a click for 20 years and it's at the very end of opening, that's probably means they've stretched that ligament out enough now that it's pretty much almost out of the way and they're kind of at that end stage of the dysfunctions. So just kind of knowing if you want to treat it or not. If they're not painful, they don't have limitations in any of their ability to eat or tolerate dental care, then I would probably leave it alone if they're at that later stage. Just educate them, tell them we'll watch it, and leave it be. Okay, so opening. All right, this has changed. The data is updated as of 2022, for those of you who have heard me talk about this before. So normal opening, right, is the range 40 to 45 millimeters, depending on what source you talk to. What do you think this kid can do? It's like Price is Right. Who wants to throw out a number? 60 something, I heard. Anybody else? Anybody going higher? 80, 101. Nice. Okay. So this is Isaac Johnson. He's from actually Bloomington. he's a local guy. And so he was, I think, I'm looking at my screen because I have it written down here. He was 18, I think, when he got this record. And his opening was 102 millimeters. Yes. So he's one of those hypermobile folks. I would wonder what the rest of his joints look like. But yeah, so if you get that patient, I mean, encourage them just to not do that a lot so that they don't get stuck. But yeah, it is pretty amazing feat, right? And it would make dental work amazing, I'm sure. You're just like, I can get all the way to the second, third molars like piece of cake, right? So, but compare that, right, to somebody who's only got one finger, right? See, of opening, you have a big range of problems that people can have. So, the largest mouth gape record, he's got the Guinness World Record. Somebody from Italy beat him, and then he got it back the year later. It was, yeah. I gave a presentation to St. Kate's Physical Therapy School, and my data wasn't up to date, and somebody called me out on it. They were like, no, actually, just last week the record changes. I was like, what? Seriously? So I checked this time. Okay, so then palpation. Don't worry, I know there's a lot of words on here, but just what you're going to do next, right? So you watch the patient move, you're deciding, okay, oh, they're really limited, or holy moly, they have a ton of motion, and maybe we're thinking the problem is too much or too little, right? And then you're going to feel on those muscles that we talked about and those joint points or those bony points that we talked about. That's why I did the anatomy review. So I'd be feeling on the patient's temples, feeling on the masseters, feeling right on the condyle, asking them where exactly it hurts them can just help you identify what's going on. All right. And then you can feel, again, the joint move. Obviously, we won't go through this here, but you can, for those of you that have had me teach you at Metro State, you can go in and put your thumb on somebody's teeth and pull on the jaw a little bit and feel how it moves. See if it's tight, see if it hurts them, see if it's restricted or not. Has anybody used that in their practice yet? That is no, yeah, do you remember it? A little bit. Okay, but you can just check how the joint moves. It's part of your exam. Okay, and then there's two special tests I want you guys to know how to do. All right, one is the clench test, and the other one's the tongue blade test. So special tests in the medical orthopedics world are tests that help kind of rule in or out a disorder. It helps you make a decision for your diagnosis and then your treatment plan. So the clench test is over here. Sorry, it's small, but it's where you put a tongue blade, or you can put a cotton roll or something thick that's going to keep their teeth apart on one side at a time and ask the patient to bite, right? Is anybody familiar with this? Nope? Okay, awesome. This will be a useful tool if you need to dig it out ever. So I think you'll have access to my presentation, hopefully, so you can always review it if you need to. But, so in this example, the tongue blade's on the patient's right, your left on the image. And so if they bite on it and you keep one side separated, what that will do is it will compress the opposite side, right? Because the joint works together like a hinge. And so what you're looking for is pain to be reproduced on the same side, the ipsilateral side, or the opposite side, the contralateral side. So if in this example, the patient said they had more pain on their left, that means you're compressing the joint, and I would suspect that the joint is more the source of their pain. If they told you my pain is on my right, on my same side that they're biting, because they're not fully seating the joint together because you have that spacer in there, right? That means more it's their muscle that's causing them the pain. And you would repeat it on both sides. So you would usually see where one of those inflamed joints, it actually feels better for the patient to bite on that side. And they will tell you, I put food over here. It's weird, but I feel better when I bite on my painful side. That's because it keeps that space in the joint and they don't fully close down. So just a way to kind of rule in or out if you think it's the joint or the muscle. The clench test. It's got a couple names. There's a few people in history that have claimed that they invented it. So I just call it the clench test to not give wrong credit to anybody. And then the other one is the tongue blade test. So that's a test for a fracture. Again, I don't know what you guys are going to see coming into your clinical days, but if a patient, fell and you're the first provider to see them, this is also an important one to know. So tongue blade test is they have to put the tongue blade in between their incisors in the front, sticking out, right? And they have to have them do it. They have to be able to physically break the tongue blade with their hand. They're holding it in their teeth and they're trying to bend the blade in half. If they don't have enough strength or it hurts their jaw too much to be able to hold that to break it, that's a pretty high sensitivity and specificity that they may possibly have a fracture. And imaging would be a good idea, or referral to somewhere to handle that. So there's not a lot of special tests in the jaw area that have a lot of high-level sensitivity specificity, but this one really does. So I like to always point that out. I've only had to use it once. So hopefully you won't, but if you're the only provider that some of these patients are seeing, you might want to keep that in your back pocket if you ever need to use it. Nope, just between the incisors, yeah. So they can't use their palate to brace it, but yeah, great question. Yep, and if they have incisors, I don't know if there's data on doing it on other teeth, but yeah, good question. Anybody had a fracture that they've identified in a patient ever? Yeah, a couple, yep, sure. Trauma, was it? Yeah, okay, absolutely. Yeah, right. Sometimes it's hard to tell if it's not displaced or obvious, but yeah. Okay, so we've done our poking on things, watching them move. Did I go back too far? Yeah, there we go. We've done a couple tests that help us rule in or out if it's the muscle, if it's the joint. So we have a theory going in our head. And then what do we do with that? So you also have to make sure that's not some of these other things. Don't worry, again, not going to read you all of this, but there's a lot of other disorders. So if it's not checking some of those boxes that you think it's musculoskeletal, then I would encourage you just refer for other stuff. This one's kind of interesting. I see this in PT some, that this is, I don't think it tells us, so I can ask you guys, what disorder is this shown in the image? So this is the hyoid bone. This is the vertebrae. Does anybody know what that is? Yeah, Eagle syndrome. The table on my left here. Got it. So Eagle syndrome, so styloid process, right? What that does at the base of the skull is it connects the ligament to the TMJ. And in some patients, it's just a genetic condition where they have an elongated one or an extra bone. This one's actually got a joint on it. And sometimes that can go all the way down into the hyoid and connect or extend or have another segment on the hyoid. So these patients usually have limited neck motion, right? As you can imagine, they're jamming into that thing. Also jaw pain, sometimes swallowing difficulties, stuff like that. So this is an extreme example, but just kind of interesting to get you thinking about that there might be other stuff out there. Anybody seen an Eagle syndrome on imaging? Yeah, okay. Yep. Were you the first one to pick it up? Yeah? Yeah, it's pretty common to have little ones that don't limit people, but yeah, sometimes you get a crazy one. And yeah, usually those patients for me are coming in and they're it's right here, it's right, I jabbed my finger in behind my ear and it hurts. I'm well, let's stop doing that and let's figure out. You're poking on your vertebrae, that's always gonna hurt. Yes. Okay. So what do we do to help these people now, okay? So here's what you can do. This is what I want you guys to come out of this with some skills that you can use. So patient education and self-care is huge, right? Probably half of what I do as a PT is education. Probably half of what you guys do as dental therapists is education, right? So telling them what you think's going on so it's less scary, right? And we'll talk a little bit more about some specific strategies that you can use. And then manual techniques, you can teach them how to do some self-massage techniques and things like that. Modalities, how to use heat or ice and why you would choose one or the other. I'll tell you about that. And then more things we do in PT. There's certain exercises, nervous system exercises, and functional activities that we can train them into that you guys don't have to dig into that far. Okay, so patient education. I'm going to drive you crazy with this, but yep, ruling out causes of dental pain, right? And then explaining to them why you don't think the problem is their tooth. Lifestyle modifications, do they need to get a sleep study done for untreated sleep apnea? That might be a problem. Is their oral hygiene care not so great? That might be probably a part of the problem. Stress, anxiety, any of those life factors that might be causing some jaw issues you'd want to be able to have a conversation about. And then referring to the appropriate provider. I'll talk about that more coming up. And then, of course, early recognition and treatment can help these folks avoid a lot of years of issues. All right, then, patient education. So, reducing the fear, and then reducing parafunctional influence. So, getting patients to not clench as much. They can't control what their brain's doing at night, but during the day, you're probably familiar with this, the two-taw positioning or the N position of the tongue. I call it two-taw, tongue up, teeth apart. So, tongue's up, teeth are apart a little bit, the little freeway space in there, right? The N, exactly. And just teaching them to catch the clenching whenever they can and correct it. They're not going to be perfect. I usually shoot for 20% change. I tell patients if you can decrease the amount of clenching by 20%, that's enough to make a big difference, usually in their symptoms. And then help them identify triggers. Is it during stress? Is it when you're driving? Is it at work? Is it when you're talking to your boss? If they can kind of find some patterns and then start to train themselves to not clench as much, that can be helpful. Reminders on your phone. There is an app, again, I have no affiliation with it, but there's an app called the Brux app, B-R-U-X, A-P-P. And what that was done is it was designed to help patients retrain themselves to not clench, daytime clenching and bruxism. And so it will give you reminders as much. It's a free app, so you guys can look it up and you can share it with your patients. It was developed by a dentist out of Italy. And it will give them reminders with an auditory tone, and they can set the frequency of it. And so the idea is that it starts to cue them in their brain to stop clenching and to decrease that habit. So it's kind of cool. If the patient just is going to get annoyed by having pop-ups on their phone, then don't do it. But I give it to people as a resource, and sometimes they like it. If you can track your progress with it, there's a program that will actually kind of titrate the frequency of the alerts over the course of a couple weeks. So it's kind of a cool program. And free, so a good resource for patients. Relaxation techniques is also helpful, right? Breathing, mindfulness. There's lots of free YouTube videos out there about it. There's lots of apps, Calm, Headspace, all of those things. I think people became all too familiar with those during COVID. But that's, again, a suggestion you can give patients if you feel like tension is a big part of their muscular problem. And then posture, right? Educating them about the importance of posture, including sleep posture. What are they doing with their pillows? How are they sleeping? Are they on their stomach with their arm under their head, shoving their jaw over one way all night? Try and get them to not do that. And then they can self-massage their muscles. Most people are already doing that themselves. So masseters, temporalis, pretty straightforward. There's techniques for the pterygoids too, but we won't get into those today. And then dietary recommendations, right? If they're really flared up in that joint, they're probably not eating chewy foods at this point, but sometimes they're still trying to. So advising them, hey, you might need to take a week or two of just softer foods to let this calm down. Yes?
What is the current
Yeah. Yeah, great questions. The question was when do you use heat or cold, and what time frame do you switch from one to the other? So acute inflammation is usually considered 72 hours. So 3 days I would do ice, and then after that switch to heat. So fantastic. Most patients I find like heat better, Rarely do I find the person that likes an ice pack on their face. But with trauma, of course, if it's swollen, yeah, ice is the go-to. And then you can switch them to heat after that. I have actually, that's a great question, because I think that's coming up. I'm going to go to this one. Yeah. So here's an idea for heat and ice. So thank you for asking that. There are Velcro pack things that you can buy on your favorite 2-day online supplier that have these 4 little packs that fit into this sleeve that Velcros onto your head, and it holds it right at like lower jaw and temporalis. And so those are really nice because you can heat them or cool them, and then the patient's hands are free to still do stuff, and they don't have to hold a pack on their face. They're around $18. So pretty doable. Most of these blue ones are what you see. If you just Google search it, you'll find a whole bunch of people selling that same looking one. So those are a nice resource. I show people that. And then the ice, an idea on the ice. These are test tubes that are not used for anything, right? But you can buy like test tubes in a big bag for super cheap. And then you can give it to the patient. They can fill it partially with water and freeze it. And then they can take that little test tube and go inside their cheek and massage it, or up in like the lateral pterygoid space, and they can kind of numb from the inside. Sometimes that's really well tolerated if they're so painful that you can't touch anything. Also kind of nice resource after they've had a dental procedure and maybe have had to have several injections during the procedure, and they're gonna be sore if it was an extraction, if there's some surgical thing done. That's kind of a nice option for them too. So, awesome. Yeah, please. No, I love questions. Yeah, for the acute inflammation, yeah, can be helpful for sure. Yeah. Right, depends on the scenario. But yeah, if the patient's, they're going to be inflamed, they're going to be sore, you want to get them over that hump, yeah, that's for sure can be a good option. Make sure they don't react to it, right? Diabetics, other reasons that you wouldn't want to do steroids. Watch for kind of a rebound of it, though, because sometimes when it wears off and the pain comes back, they're super disappointed. So make sure you give them some resources and explain to them what the course of that's going to be like. But yeah, great question. Yeah, Medrol dose pack. Another nice anti-inflammatory is topical Voltaren. Doesn't have the bang that Medrol does, but it's something that the patient can self-apply if they're just specifically inflamed right at the joint, and that's really well absorbed right in that area. It's an over-the-counter. So, yeah. Awesome. Okay. Then, tongue up, teeth apart. That's something you can teach them as an exercise. We already mentioned that before in the education section. And then there's one more I want to show you guys how to do. It's called controlled rotation. So what you can do is you can feel the joint on either side with your fingers. So I'm going to have you guys do this. So this is Abby. She's a PT student that let me take pictures of her face years ago. I'm forever grateful. So you're feeling on either side, and I'm going to have you open and close, right? And what you should feel is that the condyles just stay in place, and they just rotate. They shouldn't pop out. You shouldn't have something push into your fingers until that last like 25% of motion. So for those of you that have a clicking thing going on, it pops out when it clicks, right? So you can teach patients to feel that, to slowly open and really try and make it move symmetrically and not pop out. It helps also to put your tongue on the roof of your mouth as you do it. That'll limit you from doing full opening so you don't get into that translation phase of opening. It's just pure rotation. That's a really good one to retrain people that hate the click and are afraid of it. Because sometimes it's a little bit of a muscle control thing, can stabilize it and help calm that down. And then we function mostly in that range, right? You don't open to the full range most of the time unless you're taking a large bite or you're yawning. So if you can kind of retrain people in their movement, they can speak usually a lot better without it hurting. So, nice. All right. Then, okay, we've done what we can. We've identified the joint patients, the muscle patients, the disc patients. We've taught them some things. Then what do we do when it's beyond what you guys want to or are capable of treating? So sleep apnea screening, if you think there's an airway issue, right? Sleep physicians, sleep dentists. If they have a primary care doctor, that's fine too, but they'll probably refer them on anyway. So you might as well just send them right to the source if you can. Physical therapy, that's me. So muscle or joint problem, we certainly can help with that. And then orofacial pain dentist, obviously the specialist. If it's really complex, they've clicking trauma that you just aren't quite sure what's going on. They got some nerve symptoms, like I would go there with that referral. And then ENT, if it's swallowing or ear. Like I said, ear ringing can be a common symptom of temporomandibular disorders, but not always, so they definitely should have that ruled out with an ENT to make sure that's not the source of an issue there, or sinus issues too. So, I can't see my clock up here, so I don't know where I'm at, but I got some other fun things I'll show you too, depending on the time. Oh, I'm doing good, 2:16. Okay. So, in summary, again, recognize the symptoms. If it's not the tooth, what is it? Is it joint? Is it disc? Is it muscle? Educate and treat them, and refer them if it's not something that you are able to manage. And then, yeah, what questions can I answer? Yes. Yeah. Yeah, great question. So question was if it's crepitus, so if it's not the pop, if it's the rubby, crackly, grindy, rubby sound, right? So it can be acute inflammation if they're really swollen. That'll sound like crepitus because the fluid moving around in there. If it's really painful to touch too, that kind of clues you in. But it's going to be more that the joint disorders, the capsulitis, the arthritis. If they've kind of worn down that disc and it's actually like a rubbing of what's left of the cartilage in the bone, it'll be a crepitus sound. So you consider your patient's age too, right? With that sound, tends to be a little bit in the older population. But yes. Have you seen? Okay, so more in the yes, making it more challenging. I like it. So yeah, probably trauma. If there was a history of trauma, I would wonder if there's inflammation in the joint. If they're an early, like, and no clicking, you're saying, and no pain. Okay. Are they your hypermobile person? Do you know? Are they a dancer? Are they a gymnast? Okay, so it could be that where the joint is just rubbing more because they have a lot more motion than the normal person. So they might actually have more wear on their disc at an early age than you would expect. So, yes, good question. I know I'm not clearly answering it, but it could be a lot of what ifs. But I'm glad you asked. Yeah, I would think maybe hypermobility in that condition. And if it's not limiting them, if it's not painful, if they don't have any functional loss, then monitor it, keep an eye on it. Yeah. Anything else? Yes. Yep. Yeah, the question was, is there any correlation with temporomandibular joint area pain and wisdom tooth extraction? Yes, there can be just because of the procedure causes, right? A lot of forced end range opening, some lateral protrusion if you're kind of having to dig around in there. So yes, that can be. Obviously, the provider tries to not have that happen during an extraction, but it can be. I see it sometimes in major surgical extractions, like are you talking after oral surgery extraction or, yeah, exactly. So if it's gotten complicated, they've been open for a long time, they're getting passively stretched. So yep, that'll stretch all those structures and irritate that. So they probably have then inflammation in the joint and a lot of muscle guarding after that procedure. So the heat, the gentle massage, that sort of thing is what I would go to. And hopefully that over a week, that should start to resolve in that jaw area. Good question. Yes. Eagle syndrome? Yeah, if it's limiting their motion, surgery. Yeah, if they go in and take out that extra bone piece. Yeah. Yes. Yes.
Do you recommend against
Oh, yeah, like bite blocks, mouth props. I like those. Oh, to really crank it open. True. Yes. I mean, obviously, the dental procedure needs to be done. You know, if there's an infection or something, you can't just not do that. But, yeah, it's tricky because it's knowing the patient, right? Are they the hypermobile person? Are they not? Do they have a joint problem coming into it, you might want to be more cautious with use of those, but yeah, it can go where that will cause some problems. Yeah. Yes. Yeah. Sure. Yep. Yeah, good question. So the question was about like oral appliances or oral orthotics, night splints, night guards. If the patient can't afford one that's fabricated by a lab, like what other options are there? I would advise against over-the-counter ones. They're a softer material, right? They're your boil and bite splints typically. And that softer material will actually sometimes make them clench and chew more, kind of like a chew toy. So I find that backfires. It is cheaper, I know. So, you know, for $30, but still you wouldn't want it to make their symptoms worse. So I wouldn't have them do it. Good question. Yeah. Sure. Yeah, to wear the device versus, yeah, tooth damage. Again, might work for some patients, but I would caution it makes them possibly clench worse. So are you adding more force versus protecting the teeth? How frequently are they going through those, right? Are they getting a new one every month? Or they, you know, yeah. Yeah, that's true. I mean, proof to the patient, right? Like, you're doing something because, yes, yeah, yeah, with caution, right? Use it, but at short term, if you do, I wouldn't recommend long term if it's possible to get them, yeah, more of a hard device, that would be better. Yeah, yes. Yeah, Botox can be a good option. Yeah, it's kind of third tier in my mind. Again, being biased, being PT, more conservative first. But like manual muscle releases, stretches, can they reduce the tension, lifestyle changes, that sort of thing. If that's not effective for them, or it's a contributing factor to migraines or something like that, then usually trigger point injections are the next step, which are neurologists, MDs, dentists performing. If those aren't having a long-lasting effect, then Botox would be the third level. Botox, though, super expensive and typically not covered by insurances unless you have a migraine diagnosis. It's not covered if you only have a TMD diagnosis. But yes, definitely can be an option, but I'd put it up at like that third tier. Text neck? Yes. Right, because the posture affects the, yeah, absolutely. Studies specifically, none that I've read recently, but I would believe that there is, yeah, yeah. Yes. Yeah. Right, is there, yeah, she mentioned that, like, is there more stress? And you've had more patients that have had issues with that. Yeah, absolutely, right. All of the changes we've had in the world over the last few years. Yes, exactly. Stress, unmanaged stress, that sort of thing. More computer use, people working from home more now, more video conference calls versus in-person meetings, right? It's really kind of changed our habits. It's a big lifestyle change, right? And so, yes, that is increased symptoms for people, for sure. Yes. Yeah, I love dry needling. I use it a lot in my practice. That would be another like non-medication injection option for the muscle question. But yes, I have pretty good results with that, just forcing the muscles to reset. And then the goal is hopefully the patients can maintain with techniques that you teach them how to do. But that's a pretty affordable thing. It's usually chiropractor, PT. Some dentists, some physicians do it, but it usually falls into PT chiro realm a lot of times. Yeah. Yeah, that's a good question. That would probably depend on like your practice act, if that's included, right, in procedures that you can do. In PT, I know I can speak for that because that's what I know. But in the state of Minnesota, we have nothing in our practice act that says that we can or cannot. So therefore, we do it. Some states specifically say you can or can't do it. And so that would be something to maybe look into for the dental therapy. Yeah. Yeah, you use so those of you who aren't familiar with dry needling, it's using an acupuncture needle to insert into the muscle. So you can put it in the pterygoids, the masters, temporalis, the neck. I mean, really any muscle you can access in the body. And the idea is that it helps just kind of force like an electrophysiological reset of that muscle. You can also stimulate it, add like electrode stimulators to it, kind of like a TENS unit, and make it twitch, just again to fully force a reset in all of those like fibers and Golgi tendon organs that are firing in the muscle. Awesome. Yes. Can I show it? Yes, I can show how to palpate the lateral pterygoid. And I have 1 minute left, so I will show you that, and then I will have to wrap up, but I can hang around too. I know you guys, I'm the last thing before social hour, so everybody's getting like antsy to go to that. So if you want me to palpate your lateral pterygoid during social hour, I didn't bring gloves, but yes. Okay, so lateral pterygoid, yes, you can palpate it. It's a little bit tricky, but you can get there, so that's what this person's doing. So when I do it, I also teach patients to do this to themselves. They absolutely can. Give them those tools. If you have the time to do it in the office, do it. So what I have people do, so I usually do pinky because it's smaller, it's easier to get in there. So if you do it on yourself, you're following your bottom molars back, so you go all the way back, you move out, and you try and find that big fin of the process there. So you're looking for that bony, sharp line. So find that, follow it all the way up. So your finger, your pointer finger, your pinky is in here. You're up here. And then if you fall off of the top of that process, medially and superiorly, you're just poking in a little soft spot space in there, you're getting the lateral pterygoid. If it's so tight that you can't get your finger in there, you're kind of between your maxilla, right, and then that process, so you're in a little crack between the bones. If you can't get your finger in there, deviate your jaw to that same side, and it'll open up the space a little more, and you can get in there. Yep. Yes, that one's a doozy. I'd go for that one if patients have sinus or eye pain. In those referral patterns way back when, I can throw those back up there. Lateral pterygoid tends to give that. All right, and with that, I think I am out of time, but thank you guys for your attention. Yes, appreciate it.